Our next speaker is Elsa Rocho Quinones, who is a pediatric neurosurgeon here in Austin for a few more days. And we're going to miss her sorely. But today she is going to talk to us on Chiari Malformation, which fits beautifully into our discussion about pediatric headaches.
Thank you very much. All right, hello everybody. Thank you for standing with us. I know we're a little bit over and it's very cold in this room, so I'll try to keep it quick. I'm gonna see if I can move this properly. There we go. So I have no disclosures regarding this or any topic. Just briefly, I want to give an introduction to Chiari malformations in general. I know there's a lot of confusion sometimes to like which is what. Then take a closer look at the Chiari malformations that we tend to encounter in the community, imaging characteristics, clinical association symptoms, diagnostic imaging that are key, management strategies, surgical approaches, outcomes, et cetera, and then hopefully we have some time for questions. So Chiari malformations, they were first described by Dr. Chiari back in the 1890s. There are 4 main congenital hindbrain anomalies that were described by him. The first 3, Chiari 1 through 3, they basically consist of a type of hindbrain herniation where the herniation occurs sort of as an imprecise continuum between them. The 4th one, which is Chiari 4, was actually confused with a lot of other entities just because it's so rare that throughout the years have been described incorrectly by many, but it actually is characterized by cerebellar hypoplasia and then an occipital encephalocele, so technically herniation of supratentorial contents. Then in the more recent decades, there's been more designations about different types of Chiari malformations, like Chiari 0, 1.5, 3.5, so we won't really go into details of those today, but I'll mention some. I'm going to start with the least common ones and sort of the kind of stranger looking ones. So Chiari 4 malformation, I already mentioned, characterized by the cerebellar hypoplasia, occipital encephalocele. So let me see if do I have a laser? Kind of doesn't work very well. But the thing sticking out of the intracranial component, that's actually the supratentorial herniation there, occipital, part of the occipital lobe, sometimes part of the ventricle as well. It may involve even midline structures like the superior sagittal sinus. And if you notice in the posterior fossa, the cerebellum is smaller than the posterior fossa there. It is commonly confused with other diagnoses, but we won't get to those today. The Chiari 3 malformation is also one of the rarest and actually, I would say, of the most severe form. And it consists typically of having a high cervical or a low occipital encephalocele that basically goes through that bony defect, if you can see in that sagittal view and coronal view. This one may present with or without spinal cord herniation as well. And as you can imagine, with these structures herniating through defects, the overall mortality rate is quite high. It's 29%. It's oftentimes not compatible with life. The Chiari 2 malformation starts getting into the realm of things that we see more commonly. This one is associated to spina bifida, so it occurs in the setting of myelomeningocele. And it has some very typical features that it's important for us to understand, which includes like caudal displacement of the medulla and the cerebellum. Sometimes it may have inferior displacement of the pons as well through the foramen magnum. In these patients, the foramen magnum is actually quite wide. It's very wide compared to other Chiari patients, and I'll show you a comparison in a second. They also have some typical imaging findings like herniation of the vermis and large massa intermedia. They have elongated fourth ventricles. Sometimes they have callosal dysgenesis and beak tectum, et cetera. Certain of these findings are important for the surgeon, particularly when they're planning on any potential interventions, particularly the low-lying torcula, because they have venous structures that can be quite close to your decompression site. But luckily, in the more recent years, we've started to understand that in these patients, kind of the symptoms that were once thought to be related to the compression of the brainstem, like having stridor and problems with breathing, et cetera, they're not actually due to the compression, but rather from brainstem dysfunction. So nowadays, you don't see Chiari 2 malformations treated surgically, but rather treating the primary problems like hydrocephalus, et cetera. Now, in Chiari-1 malformations, there's a lot of controversy into what should be the definition of it. Is it more than 3 millimeters of caudal displacement of the cerebral tonsils? Is it 5, et cetera? Well, I would say that anything that greater than 3 to 5, it's been kind of agreed upon. Mostly we go by greater than 5 millimeters of tonsillar displacement. But if you see any other associated findings, like a syringomyelia, which is an abnormal fluid accumulation in the spinal cord associated with a greater than 3 millimeter tonsil, then we'll diagnose that as a Chiari malformation. You may have Chiari malformations being congenital versus acquired, so knowing and ruling out a primary reason or etiology, such as hydrocephalus or an intracranial tumor, pseudotumor cerebri, et cetera, is very important, because then when we're focusing on management, we want to treat the primary etiology first. Chiari malformation can be associated with syringomyelia. About 25% of cases may be related. It's certainly higher rates of syringomyelia in some more complex cases, which we'll talk about. In some of the complications that we can see with Chiari-1 malformation, which is, I guess, our simpler form or more common one, are related to skeletal abnormalities and congenital anomalies that can include atlantoaxial instability, platyphagia, basilar invagination, et cetera. And this is just a picture on the left side of typical Chiari malformation. That's just a zoomed in version where you can see the tonsillar descent across the foramen magnum. Now, for those alternative Chiari designations that I was talking about, the Chiari 1.5 malformation has had a lot of discussions lately. You could think about this as just a complex form of Chiari-1 malformation, where essentially it meets all of the criteria of Chiari-1 malformation with regards to the cerebellar herniation, but there's also an additional just appearance of elongated fourth ventricle and also kind of caudal descent of a part of the brainstem or brainstem kinking, which you can see in that picture on the left side. The picture on the right is a different patient who had Chiari 1.5 associated with a syringomyelia, and this patient has already been decompressed. So if my laser worked any better, I could probably point at I cannot. But basically, the posterior fossa, you can see that there's more cerebrospinal fluid in the back of it. Part of the bone from the occipital region has been removed, and there's been a duroplasty, meaning that that dura has been augmented. So it's kind of the primary way of treating something where we see already there's compression and an associating syringomyelia, which I'll go over a little bit more later. Now, the Chiari-0 malformation has also been more of a kind of recent description and is very interesting and controversial because in this form, there is no tonsillar descent. There is technically no obvious craniocervical compression syndrome, but there is actually syringomyelia that is thought to be related to kind of arachnoid adhesions and just basically obstruction of the obex and CSF flow. The way that these patients have been diagnosed with a Chiari-0 malformations because they've already undergone treatment for posterior fossa decompression and had improvements in their symptoms and or syrinx with reduction of the size of the syrinx. Now, going back to the Chiari type 1 malformation, which is the more common than what we're going to find, their symptoms are associated to kind of three major things. CSF obstruction at the craniocervical junction, which will give you that typical Valsalva-induced occipital or upper cervical headache, and symptoms that are similar to hydrocephalus symptoms, like any intracranial pressure symptoms, nausea, vomiting sometimes. They may not be the typical headaches or typical symptoms, but they can be, they have been reported. So patients that present with these symptoms, I do often consider even visual evaluations to make sure that they don't have papilledema, because even though it's not a majority of them, about 15% of them have been reported to have papilledema associated with it when it's been severe. Now, symptoms associated to cerebellar brainstem or cranial nerve dysfunction have also been reported, and of course, these are the ones that trigger our questions of making sure, like, well, are you having any swallowing difficulties, coughing, choking, aspiration, difficulty with snoring at nighttime? Any question of central sleep apnea or obstructive sleep apnea should be looked into with these patients. And I would say less common, but also reported have been those autonomic symptoms related to POTS, et cetera, syncope, drop attacks, sinus bradycardia, and tachycardia with postural changes. That's definitely a lot more controversial, but it has been seen particularly in patients with connective tissue disorders. And the final spinal cord dysfunction symptoms, mostly related to the syringomyelia, you can see scoliosis, which more commonly will have thoracic levoscoliosis, so the curve to the left side. So you definitely see that in one of your patients, and the younger they are, it's a very red flag, and you do want to look into it, get scoliosis films, and do the full evaluation. And then you can see upper, lower motor neuroscience, motor weakness, spasticity, sensory changes as well. But by far, everybody, and especially surgeons, will focus on, well, what about the classic Chiari headache? Do you have the classic symptoms that could potentially put you in a category of patients that is more likely to benefit from an intervention from decompressing your posterior fossa? So those are the occipital or upper cervical headaches that are Valsalva induced, like coughing, choking, sneezing, laughing. If you're straining in the bathroom, is your kid coming after that, like crying and telling you that my head hurts because I was trying to go potty? So that's one of the things that will tip you off. And these headaches tend to be of short duration, so that's one key as well. So associated comorbidities are very important with these patients because it definitely changes kind of the severity of their presentation and also just the complexity of their Chiari and the potential need for surgery. So these anomalies that have been here are just a handful of the ones that have been recognized. And skeletal anomalies, multiple congenital anomalies, undiagnosed craniosynostosis symptoms or syndromes, those are very important to rule out. Like I said, also connective tissue disorders have been linked to this because there's been an association with actual hypermobility and lentoaxial instability, cervical instability leading to these problems as well. As a matter of fact, the things that have been, or I guess like the different aspects of their management and their presentation that have been looked into, age diagnosis is one of them. So for patients who had multiple congenital anomalies or skeletal anomalies, actually the age of diagnosis has been lower, and it's thought to be because it's more severe. The tonsillar descent in these Chiari patients is also higher, meaning that it actually descends a lot lower for these patients with multiple congenital anomalies. Similar situation for the obex position. And the rates of hydromyelia have been higher in patients with both skeletal comorbidities and multiple congenital anomalies, particularly the ones in this list. And of course, as you can imagine, then the rates of posterior fossa decompression surgery have been higher for those same patients. And as you can imagine, then incidental Chiari malformations, or the bread and butter, basically the ones that we encounter the most, are typically non-syndromic patients. So we get asked a lot of what should we get or what should we order for imaging. And I would say that tonsillar descent is very commonly found in incidental imaging, now with the ease of getting a CT on everybody, particularly post-trauma. But it's definitely not the imaging mode of choice. So MRI is still the modality of choice. And in a patient with a very high suspicion, like Dr. Ong said, or a confirmed Chiari malformation, you definitely want to get brain and spine imaging. It's recommended because you want to rule out hydrocephalus, supratentorial lesions, and also want to evaluate for serrings and other coincidental spinal anomalies that will help us kind of risk stratify these patients into their management subsequently. Cine MRI is a modality that has been helpful for some. It's controversial as well. It actually helps to assess the CSF flow and the dynamics of the tonsils around the foramen magnum. Where essentially we look at, is the flow looking normal or not? Sometimes it's really non-diagnostic and you just don't know. And you have to go with your initial kind of gut instinct. But there have been some studies, including one by our very late Dr. George, who they looked at the correlation of these patients with abnormal CSF flow on cine MRI, and they actually had a positive correlation of post-op symptomatic improvement as well as improvement of their CSF flow after decompression. So some people still use it as part of their management strategies to kind of stratify these patients. Now, if we have patients with known bony abnormalities, such as basilar invagination, the clipophile, like cervical fusions, atlanto-occipital simulation, it's important to get cervical dynamic films, essentially like cervical flexion extension films, to make sure that they don't have cervical instability, because these patients may actually need to be managed in a different way with regards to their posterior fossa decompression and potential stabilization. So these strategies I keep talking about, you can imagine that there's significant variation you ask a group of 10 surgeons and you're going to get 10 different answers of how to, how to do this. But I think that there's some generally agreed upon principles, primarily if this is an acquired Chiari, with a clearly identifiable etiology, you want to treat that first, right? If months later you have symptoms that persist and they're referable to the Chiari, then you may consider surgical decompression, but all in the knowing that if symptoms are not classic, you may not necessarily have an improvement in certain symptoms. Now, asymptomatic or non-classic symptoms, no syrinx, you can consider conservative management and follow up clinically and also with imaging. Asymptomatic or non-classic symptoms with a syrinx, if the syrinx is mild, you can consider conservative management and very close follow-up with imaging reevaluation. If there's any worsening of the syrinx or worsening or new development of symptoms, then consider surgical decompression. And with symptomatic patients, if you have the classic Chiari headache, no syrinx, but very debilitating symptoms, consider surgery. Classic Chiari headache with a syrinx, we usually recommend surgical decompression. And if you have any of the cranial nerve dysfunction, brainstem compression, or spinal cord dysfunction symptoms that seem to be referable to the Chiari, then certainly surgical decompression would be recommended. For the surgical strategies, it also varies a lot, but in general, I think the bulk fall under just suboccipital decompression with potentially bone-only decompression versus dural splitting, dural augmentation, meaning that we do a dural patch to turn that area from having like a medium-sized shirt to an extra large-sized shirt, okay, and give more space to that. Here, this is just an example of dural splitting, where essentially you can compare that to just moving the button down on your belt and giving a little bit more space. Versus just doing the kind of the full works and opening the dura and exploring to see if there's any arachnoid adhesions, like the ones that you see on this fourth ventricle right there on the left side in the lower image, where there's sort of like a membrane that's forming a bubble, and then opening that to allow CSF to flow freely. When these strategies have failed, and patients needing redo surgeries oftentimes, then not often, it's not very common, but they may undergo placement of fourth ventricular stents. And with the minority of patients, like the ones I mentioned with potential cervical instability or skeletal abnormalities, in the more recent years, groups have actually looked into ventral decompressions with occipital cervical fusions, but that I would say is definitely a minority. So what we know so far is the classic Chiari headache symptoms tend to improve after decompression. The syrinx resolution or significant reduction can be seen in 80 to 85% of the patients after that initial decompression. But syrinx recurrence definitely may occur still years to decades after improvement, just kind of highlighting the importance of having a long-term follow-up for these patients and taking their symptoms seriously if their headaches recur. It's not something that we want to dismiss thinking like, well, you've already been decompressed, you should be good. So scoliosis, when it presents with syringomyelia in these patients, if it's less than 40 degrees, it will commonly stabilize or improve, particularly in patients that have not reached their bone maturity or less than 10 years of age. And like I said, a minority of patients with significant ventral compression and showing up with medullary dysfunction that also have potential lentoaxial instability, dynamic films will be helpful. Sometimes even doing preoperative assessments with cervical traction if they have improvement, then may determine the need for an occipital cervical fusion. So some closing remarks. Chiari malformation, definitely often diagnosed incidentally. Most cases will be non-syndromic and simple, but some can be very, very complex. That presence of comorbidities will be very important. It impacts the rates of syringomyelia development and also the need for surgery, so it's important to look into that. And although most of them are non-syndromic, you want to be very thorough in your clinical evaluation and looking for growth parameters, meaning head circumference, and are they too short? Do they have any hormonal deficiencies or any vitamin deficiencies can be related to that. Scoliosis examinations and evaluations for joint hypermobility, which can be quite simple and done with the Bainton's test. Especially because they can have differing rates of syringomyelia and the need for surgery. And then finally, just posterior fossa decompression. It appears to be effective for properly selected patients, definitely not without risk, but something that if you have any questions about patients that may need to have a referral, just definitely reach out to your neurosurgery group because we don't want to have these patients get lost through the cracks. Okay. And some references that I've selected from here. I'm happy to take any questions if there's any questions.
Thank you very much for the talk. Just curious, for those patients with asymptomatic, how often do you do the imaging follow-up? Is it 6 months, a year? And then with those like asymptomatic but with syrinx, how often do you also do the imaging?
That's a great question. So for asymptomatic patients, and this will vary a lot depending on preference of the surgeon, but if there's no syrinx associated in the initial imaging, I will just wait for a year typically, and or sooner if there's any symptoms that change, et cetera. If there's a syrinx present, I tend to prefer the shorter course, like just maybe re-imaging in like about 6 months to make sure that the syrinx is not increasing in size. That's a great question too. So it actually it depends on the age for the patient as well, because we know that the degree of tonsillar descent and the evidence of cerebral hydromyelia, it actually changes with age. Sometimes you see improvement in it just based on just anatomical evaluations that have been done with different age populations. So it's kind of dictated by their symptoms. How symptomatic are they? How reliable are they with reporting symptoms where we may or may not hear from them, or they may not catch the symptoms, and really you just want to be able to do that neurological evaluation yourself and know that nothing's changing, plus also getting the kind of the objective imaging evaluation. So when they're really young, sometimes I do watch them until at least like they get to preteen, teen, and teenage when they're able to like really tell us what's happening. And we may have just multiple ways of looking at their symptoms, right? Like depending on the level of suspicion, I may have them not only just follow up with us, but if we're treating conservatively, then we don't want to have them suffer with their symptoms, even if they're not classic. We want to refer them to Dr. Pavitt for headache management, or we want to make sure that they're seeing you to rule out like the development of papilledema, et cetera. So we'll make sure that they have sort of follow-up and a close clinical monitoring in one way or another, particularly if we feel like some of the symptoms may be missed by the families, although they often are not. Families tend to over-report, if anything, but you still want to make sure that you have that coverage.
Two quick questions. One to follow from Harry's. Should we be referring, anyone who has an asymptomatic sort of incidental finding, even if it's, 5 millimeters below the Freitman magnum?
That's a great question. I would say yes, if there are significant questions about any potential symptoms that may overlapping, that you're not quite certain if they're referable to that, if the patient seems to have any other comorbidities, parental anxiety, et cetera. In reality, it's a conversation that we can have, because we can determine also how close do we need to monitor these patients, or do we follow them as needed, right? And that education, that initial education with the family is very key, because we can talk to them about the natural history of the Chiari malformations, right? What things to look for, what are the potential management, things that are going to tip off our management one way or another, so that they're very understanding of that. And getting a sense of truly how well they understand, how they grasp it, then it helps us to know, how close do I need to keep this kid on their supervision by neurosurgery, and do we trust to just let them be on follow-up with as needed patient or not, or as needed basis or not. So I would say you're not going to go wrong with referring a patient to neurosurgery for that. There's going to be a very simple initial evaluation where we don't need any more follow-up with you, and especially if they have absolutely no symptoms, versus we should keep this in check, or maybe we need more imaging to look at this other association, et cetera. So, but great question. Thank you. All right. Thank you very much, everybody.